Welcome to This Week in Health IT News, where we look at the news which will impact health IT. My name is Bill Russell, Healthcare CIO Coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. This week, as you know, I'm doing a series of interviews with health system executives who will share their plans around COVID-19 preparedness. And just want to let people know, if you're a system with best practices to share, shoot me a note, Bill at thisweekinhealthit.com, and we'll do a 10 to 12 minute Zoom video conference, which will hopefully benefit the industry. And I want to, again, thank Sirius Healthcare, who reached out to me last week and asked if they could sponsor this series of conversations to help the industry prepare and also to celebrate the great work that health IT is doing around the country right now. And I appreciate their commitment to the show and to the industry that they serve. Today's conversation is with David McSwain, the CMIO for Medical University of South Carolina and MUSC. Good afternoon, David. Welcome to the show.
Thanks, Bill. I'm really excited to be here. You have been one of my health IT mentors from well before you even knew me. I know we had that conversation in the past, and I think you are probably that for a lot of people that listen to your show.
Well, I appreciate you saying that, and this is how we met. I mean, we essentially met through David Benzema and through the show. We sort of connected that way, and we have been planning this for a while, that we were actually going to have you on the show. And we will again later. But this is a great opportunity to talk to you, because you actually have three roles that you are currently playing. And there's an opportunity to really talk in depth about telehealth. So why don't you introduce the three roles you're playing, and we'll go into the conversation.
Yeah, so first off, I'm a pediatric intensivist. I came out of my fellowship at Duke in 2009, came straight to MUSC. I've been practicing pediatric critical care since then. I've been working in telehealth for over a decade, started with a pediatric critical care program to reach out to community emergency departments, and really have been heavily involved in the development of telehealth, both at MUSC and nationally since then. And then for the past 2 years, I've been the Chief Medical Information Officer at MUSC, focusing on the integration of technology across the board into our clinical practice.
Yeah, and MUSC is just like every other organization. You guys are expanding your medical group, your geography, and increasing the services that you offer. Talk a little bit about the NIH grant and the stuff you're doing in that area. That'll set the context for this conversation, I think.
Sure, yeah. Like I said, I did a lot of work on the national level, first through the American Academy of Pediatrics, who's really been great in supporting quality, safe telehealth practices. And through my work at MUSC and with the AAP, we developed this organization called Sprout, which supports the development of multi-center telehealth research projects to prove the value of what telehealth provides. And we got an NIH grant last year. It was a $3.6 million grant through the National Center for the Advancement of Translational Science to actually develop these tools and resources around the country to support these studies. And our work specific to COVID-19 is we're developing a COVID-19 guidance on metrics to use in evaluating your coronavirus-related telehealth programs, and trying to provide some standard metrics and measurement frameworks that we're going to disseminate around the country.
Yeah, it's interesting. So I've talked to a bunch of health systems. Everyone's standing up telehealth very rapidly, or scaling it very rapidly. I've heard of people standing up training rooms. They're just training people left and right. They're standing these things up. And it's appropriate, and that's what happens in the time of a crisis, and should happen. But there is this sort of sense in which how are we going to know if it was effective? How are we going to know if this was the right approach? What aspects of this are we going to memorialize or cement into our ongoing care practices once this is over? And I mean, there's so many questions to go, but before I go there, I want to give you the chance to highlight what are some of the things that MUSC is doing from a COVID-19 preparedness in your community.
Sure. I mean, MUSC has been doing telehealth and virtual care for well over a decade. And so we have a lot of infrastructure and a lot of talent in place that can respond to this really effectively. We have a number of different initiatives, many of which are already rolled out. We have a virtual urgent care platform that we're using for screening of patients with concern for coronavirus and directing them through a drive-through testing facility in a parking lot outside of one of our buildings. That's something that we've seen at a number of facilities around the country, but we were one of the first ones to stand that up. We also are using the tools available within Epic to allow providers to substitute their in-office visits for virtual visits, either using video or using telephone, and still be able to bill for those services, still be able to document within the medical record. And that allows us to protect patients and protect providers who may be concerned about having those in-person visits. We're developing a remote home monitoring program for patients who do test positive for COVID-19, and that's going to utilize patient-entered data as well as peripheral devices like SAT monitors with Bluetooth connectivity, going through a mobile application with a FHIR connection into the electronic medical record, using creating a registry and being able to disseminate that data. We're setting up a EMS telehealth program so that our first responders can utilize telehealth and hopefully prevent some of those patients from coming into the ER. And then we're using what we call virtual PPE, personal protective equipment, because one of the really key one of the things that a lot of people are really scared of, including those frontline providers, is the critical shortage of personal protective equipment for our healthcare providers and for visitors to the hospital. So we're using our telehealth capabilities, particularly in the new Sean Jenkins Children's Hospital that just opened a few weeks ago and has telehealth in every inpatient room that operates through Epic. It's very fortunate that we have that in place, because now we're able to allow our providers to be virtually present in the room, to allow family members to be virtually present in the room for patients who would otherwise be under extreme isolation.
So we're gonna dive. There's so many things I could have talked to you about right now, but we're gonna dive deep into telehealth. It sounds like you didn't stand up a whole heck of a lot of new things. You leveraged a lot of things that were either already in place and well established, or things that have started and you just scaled them up somewhat.
Absolutely. And that's really the key. And that's where we're fortunate, because we put in so much work over the years to try to create an infrastructure that would allow for a response like this. The Sean Jenkins Children's Hospital implementation was years in the making. And the key issue there is to get it to work from within our electronic health record so that providers are going into that record to initiate the visits. It provides more security and more privacy and allows them a better workflow. But the presence of those tools allowed us to leverage that quickly. And having the personnel with the expertise to be able to respond quickly has been incredibly beneficial. So
David, you have a ton of experience with this. And back when I was at St. Joe's, we were just really starting to stand this up and scale it out for patient access. We had telehealth, we had telepsychiatry, we had we had a whole bunch of tele solutions internally, but the external solutions we were just starting to stand up. And as we were doing that, we found that embedding it in the workflow was key. We were talking earlier, and you said, telehealth can be a bridge to nowhere very easily, and we found training to be important, and because people don't. This whole screen experience is a good example. I have a lot of guests who come on who don't know how to make eye contact, who don't know how to, they have light behind them and whatnot, and their microphone's not set up. There actually is training around just doing this basic conversation. So what would you say to people who maybe aren't as far along and they are now ramping up very rapidly to really create the integration that's necessary for this to be effective?
I would say first, in a situation like this, you really have to integrate with the other resources across your institution. You can't do this by yourself. You can't do this with just a small group of people. there are a lot of people, particularly in your IT organization, that probably know some tools that could be used and that certainly understand the technology. And one of the huge, the silver linings to this situation is that it has, in many ways, forced places in the country and also at MUSC to gain improved alignment of what we're doing as an organization, and to have visibility into everything that's going on, to have all of our leaders and our staff really aligned with these efforts. And if you're a new organization, I think the first thing, make sure that you are reaching out to others in your organization to build that alignment. And second thing is to look for resources that are available across the country to support the development of telehealth programs. That includes the telehealth resource centers. There's regional telehealth resource centers that are supported by HRSA. There's national telehealth centers of excellence supported by HRSA. MUSC is one of those. The other one is at Mississippi. There's Center for Connected Health Policy out in California. There's a number of different resources that you can reach out to help you get these programs started up. I think the first thing, and of course we have Sprout, although we're more focused on the research and evaluation of programs. I would say the first thing is to reach out to your regional telehealth resource center to get some assistance.
All right, I'm going to put you in a critical situation. We're going to role play here a little bit, and I apologize. I didn't give you any heads up on this, but let's assume you and I are in a health system. We haven't done anything. Well, there's nothing stood up, and we're now in the middle of this crisis, and somebody says, let's just use FaceTime. I talked to my mom on FaceTime last night. Let's just get these doctors using FaceTime with their with people. If these are the only tools we have available, and we can't go to American Well tomorrow and can't go to Teladoc tomorrow, and we're going to struggle to do the integration that we need to do right now, what are some of the key things we're going to have to stand up if I put you in that situation? I'm glad you're not in that situation, by the way.
Yeah. No, it's an excellent question, and it's one that a lot of people are facing. And I think, and also very timely that you mentioned Facebook and those types of solutions, because there's guidance from the federal government that came out 2 days ago, I believe, that said that in the coronavirus, during the coronavirus response, non-HIPAA compliant solutions can actually be used for delivery of clinical care in coronavirus response.
So we could stand up Zoom just like we're doing right now, and this could be a mechanism.
Yeah, and I think Zoom is actually HIPAA compliant, but finding those video conferencing tools that you can use, you can stand up quickly and cheaply. I don't want to get into seeming to endorse products, but I'll say, there's one called Doxy.me that is free, that provides easy access to providers around the country. You can use, relatively inexpensive services like Zoom. And in this situation, you can use things like FaceTime, Google Hangouts, Skype. But the key thing there is, there's more to a telehealth consult than just that video connection.
Yep.
You really have to make sure that you know how to document, you know how to bill, you know how to get the records, into your electronic health system. Because if you're doing the visits, if you're doing the visits, and I didn't mute my phone.
You mean people are actually trying to get in touch with you with the 3 jobs that you have?
Yeah, no, I'm a little popular these days. Oh my goodness. Okay, let's see here. How can well, we may just have to deal with that. So if you just do the video consultation and you don't have the right systems in place to be able to get that information into your electronic health record, then you're shooting yourself in the foot. You're not getting the revenue, you're not getting the documentation. And so that's, again, where you have to work across your institution with your informatics people, with your IT people, with your data people, with your health information management people, and make sure that you know how to make that work.
Yeah, and if you and I were like in this triage mode of we don't have anything, we have to stand this up, we'd probably select something simple, FaceTime, Zoom, whatever, or the solution that you talked about. All right, we've established that video connection. Then we'd have to do a significant amount of training, maybe create some templates in the EHR, because essentially what's going to happen is you're going to have the tele-solution over here on your screen, you're going to have the EHR on this side of your screen, and you're going to be documenting as you're having a conversation. But it would be helpful if the templates were already in place that you just I mean, I already have that stuff. That way, now it's kind of manual, it's kind of clunky, but that could work for documenting those kinds of visits, right?
Yeah, and the other thing is, since this is so front and center in the coronavirus response, most of your EHR vendors, a lot of your technology vendors are providing guidance on what to do if you're standing this up quickly. So you can get guidance on what to do for that. But I think, working with your teams in how to get the basics of how to be compliant, how to document, how to bill, and then the technology really takes care of itself now because they've opened things up so much. Yeah, and that's the thing is, I wouldn't introduce a lot of variables at a time of crisis. So just personally, I would focus in on the technologies that work in your market. If all of a sudden, Zoom is overwhelmed, but FaceTime or Facebook or Google Hangouts, whatever one's working at that point, I'd have a plan A, plan B, plan C, plan D, and whatever people are comfortable with, just use that as your video connection, because quite frankly, a lot of things can work for that. And some people are saying, well, do you run out and get American Well right now? Well, if you don't have American Well now, I'm not sure running out today and standing it up is the smartest thing to do. You're introducing a lot of variables in a very short period of time. Right. And I think this will pass. And ultimately, you may not have the ability to utilize a non-HIPAA compliant video conferencing tool. And so as you're doing this, you need to be thinking towards the future of how can we make this sustainable? Because the goal really should be, this should initiate a transformation of the way we deliver care. But in order to do that, we have to do it the right way and make it integrated. And you have to have forethought and think about, how are you going to transition once this crisis situation is passed? That's a critical part. And we've already gone over, but if you allow me one more question, I would really appreciate it. And that is, what of these things do you hope stays around? So we've relaxed cross state lines. We've relaxed some of the HIPAA high-tech stuff. I assume that stuff will come back, snap back as soon as this is passed. We have reimbursement for telehealth that we didn't necessarily have before. What are some of the things that you hope? And we have new habits that are forming. People haven't. One of the things is we found that people who use telehealth love it, but we just couldn't get enough people to use it. Was one of the things. So we're now in the process of changing behavior across the board. So what of these things do you think will take hold, and what of these things do you hope doesn't really snap back to the way it was? I go to integration with the medical home, integration with established care providers, and care coordination. What we're seeing right now, particularly, is providers from around our institution saying, how do I see my patients? How do I reach out to my patients? How do I work with my colleagues remotely to be able to coordinate care? And really, when you think about telehealth, to me, the greatest potential value of telehealth is reaching out into the homes to provide care for the most complex, the most expensive, the most complicated patients that really need that care coordination, that need that remote home monitoring, that need that multidisciplinary collaboration to occur. And whatever, I think there's going to be some of these relaxed regulations that are going to get pulled back. But if we really want this to transform the way we deliver care, we need to look at how do we maintain that ability of telehealth to provide that connection across multidisciplinary teams and into the home for the patients that really need it most. This is going to be great. I really appreciate this conversation. I'm glad we were able to memorialize this conversation because
I think a lot of people post this will look back and say, what happened during this time frame, and what things should we hold on to? And I think this does change behaviors, and telehealth will be one of those things that we will look back on this and say that was a catalytic event and a real moment that changed how we think about delivering care. And we, quite frankly, as you know, because you've been studying this, if we can increase the number of touch points between care providers and the people who need the care, we're actually going to get better outcomes in the long run. So, hey, thank you very much for your time. I really appreciate it, David. Are you active on social media? Do you post, or where would you post?
I am somewhat active on social media. I do have a LinkedIn profile. That's where I do most of my social media business related work. I do have a Twitter handle. I don't use it a ton. I think it's D McSwain MD. But certainly happy for folks to reach out. And these days my inbox is a little chaotic, so hopefully things will calm down just a bit.
That's what I'm hearing. I'm hearing that everybody's email inboxes have doubled, and it wasn't good before. So
yeah, 3 jobs, so it's raised to like the 6th power.
Yeah, I understand. Well, thanks again, David. Appreciate it. That's all for this week. And special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. This show is a production of This Week in Health IT. For more great content, check out the website, thisweekhealth.com, or the YouTube channel. If you want to support the show, best way to do it, share it with a peer. However you do that, send them an email, send them a note, or DM them, whatever you do. Just that's what you should do. We'll be back again with more interviews. We're going to keep this going through next week. I already have a couple more interviews lined up, and we will continue to release those and hopefully benefit the industry as a whole as we continue to progress through this. Thanks for listening. That's all for now.